Okay, this chapter, chapter 6, is speaking about fluid, electrolyte, and acid-base imbalances. And we spent a lot of time in A&P 2 discussing this chapter. And since A&P 2 is a requirement of this class, I'm going to try to minimize the pain of going through this entire thing again, but we'll work through it and try to accomplish this as easy as we can. Some people find this information boring. I don't, but it is very involved and it's a lot of chemistry. So we'll try to suffer through it together and hopefully it'll have a positive outcome for all of you. All right, so we find that there is a certain amount of water that's in the body. And the A&P book that I use refers to this general amount, average amount, as 40 liters. And they don't really say an amount here, but they do mention that whatever the fluid volume is, 2/3 of it is found inside the cells. That's your intracellular fluid compartment. Extracellular fluid compartment makes up the other third, and that includes things such as plasma, intravascular fluid, interstitial fluid, that's what's in between the cells, cerebrospinal fluid, and there's other transcellular fluids, all your various secretions, serous membrane, synovial fluids, humors of the eye. So that's where the fluid in the body, that's part of the body, is located. These are your sources where water comes from, where it goes, and those amounts should be equal. Total in should equal total out. So liquids that you ingest, 1,200 milliliters on average. Solid food contains some water, 1,000 milliliters there. Water of cellular metabolism, that's when the cells use glucose and create ATP. Water is a byproduct, 300 milliliters there. And then losses, urine makes up the most fluid loss, 1,400 milliliters. Feces, 200, lungs, 400, because air is hydrated when it comes into the lungs, so there is a fluid loss there. And then skin, through transpiration, evaporation through the skin, considerable loss there. Control of fluid balance, the control center is the hypothalamus, and the hypothalamus has osmoreceptors that respond to changes in solute concentration in fluids such as blood, plasma. ADH is a hormone that promotes the reabsorption of water from kidney tubules, and aldosterone, we know, promotes the reabsorption of sodium, and with it comes water from kidney tubules. This is looking at different mechanisms of movement of water and electrolyte between compartments. So this is showing you a capillary, and it's showing you interstitial fluid, and then it shows you a cell. So you can see here's the capillary, here's the interstitial fluid, there's your cell. So filtration, that's what the kidney uses. Differences in hydrostatic pressure on one side of a capillary bed, and then exiting the fluid pressure changes. And if you increase the pressure, then the fluid will move from one place to another. Diffusion is the movement of solutes from a region of high concentration to low concentration down a concentration gradient from high to low. Osmosis is the movement of water, and the water moves from a low concentration of solute to a high concentration of solute through a semipermeable membrane. And then you have ATP-driven active transport processes that usually move substances against the concentration gradient from low to high. And this is when cells want to take things in. So those are your 4 basic mechanisms of movement of substances between cells or between compartments. Now, edema is a problem where you have an imbalance, where water shifts from one compartment to another, and it's fluid excess. And usually these are the 4 things that are common causes of edema. High capillary hydrostatic pressure, where high blood pressure or some kind of a blockage or something where the fluid is forced out of the capillaries and into interstitial spaces, and it's not returning. Loss of plasma proteins. So if you don't have enough proteins, these are part of the solute concentration or load that keeps fluids in the bloodstream. Because remember we said fluid's going to go where the solute load is the highest. So if you upset that balance by either your kidneys losing a lot of protein because they're failing, or the liver's failing and it's not making the source of these proteins primarily is the liver. So if the liver's failing and you're not making them, then you don't have those solutes to hold the fluid in and the fluid seeps out. Lymphatic obstruction, remember lymphatic vessels are dead-end streets, so wherever the blockage is, distal to the blockage, you will have inflammation and swelling. And increased capillary permeability, you see this a lot of times with an infection or allergic reaction where capillaries will release a lot of exudate into the surrounding fluids, but if it's extensive, then you could lose a lot of fluid and cause swelling. So those are 4 major causes of edema. So some of the effects: swelling, pitting, and with pitting, if you press on a person's skin that has inflammation, it leaves a depression when the pressure is applied to the skin. Increase in body weight, functional impairment, pain from pressure on surrounding nerve endings, arterial circulation may be impaired, and if it is, that could result in those tissues downstream from those arteries dying and undergoing necrosis, and eventually over time ulcer formation. Causes of dehydration: vomiting or diarrhea, excessive sweating with loss of sodium and water in the process, diabetic ketoacidosis, loss of fluid, electrolytes, and glucose in urine, insufficient water intake. Many times a person who's elderly, they may not think about drinking water, or a person who's unconscious and depends on others for their sources of nutrients and making sure they get enough water. Effects of dehydration: dry mouth, thirst, weight loss, low blood pressure, fatigue, weakness, dizziness, increased temperature. These are all effects that occur due to dehydration. So now probably the most boring part of this chapter, you may think, is talking about various electrolytes. And it's kind of a review really, because we did talk about all of these, so just filling in the gaps if you need to do that. So hyponatremia, too little sodium, this is your major extracellular cation. Some of the causes: excessive sweating, vomiting, diarrhea, diuretic drugs, low aldosterone, high ADH, renal failure, excess intake of water. But the main thing you will see most times, it's not that you don't have enough sodium. It's usually a result of having too much water relative to the amount of sodium, which dilutes it and results in hyponatremia. This is what you'll see a lot. The effects of not having enough sodium: remember that sodium is a main player in depolarization of membranes, so nerves and muscles are going to be affected by not having enough sodium. So impaired nerve conduction, fatigue, muscle cramps, abdominal discomfort, low blood pressure, and shift of fluid into cells, because sodium is very important. It's an important electrolyte, keeping fluids where they need to be. And if you lose it on the outside, the fluid comes in the inside. Hypernatremia, low ADH, loss of thirst mechanism, watery diarrhea, prolonged periods of rapid respiration. The problem here is a major shift of water out of the cells. And you're thirsty, weakness, lethargy, edema, and increased blood pressure. Not normally really a common thing, but it does happen with people if they're sick for a long period of time, or they're just not drinking enough water. Potassium is kind of sketchy because it's very diffusible through the membrane. It's normally found inside the cells, but it's diffusible, so if you have an imbalance one side or the other, it'll shift to change positions to balance itself out. And when we're talking about hypokalemia, we're talking about what's going on outside the cells, not inside. So if you have too little potassium outside the cells, it could be because of diarrhea, diuretic drugs, increased aldosterone, and decreased dietary intake. Alcoholism upsets electrolyte balance severely. Starvation diets, of course. But the problem, and the thing you want to remember here, is potassium and sodium are on an exchange system. If you're holding back sodium, you're going to be spilling off potassium, and vice versa. So, hypokalemia. what it will do is it will hyperpolarize the membrane because potassium is going to move out of the cell into the interstitial spaces, and that's going to make the membrane more negative, and so it results in cardiac dysrhythmias, muscle weakness, paresthesias, anorexia, shallow respirations, impaired renal function in severe cases. But it really causes havoc with the heart. Hyperpolarizes the membrane. It cannot, the heart cannot respond. Hyperkalemia, so too much potassium outside the cells. Usually renal failure. You can't balance sodium very well. Decreased aldosterone, potassium-sparing diuretics, severe injuries that cause leakage of intracellular potassium into extracellular fluids or as a result of severe acidosis. Now, what can happen here is you wind up hypopolarizing the membrane, and you can end up causing heart problems as well. Hyperkalemia and hypokalemia have dire effects on the heart. Now, calcium. Too low levels of calcium can result from hypoparathyroidism, malabsorption, retention of phosphate causing secretion of calcium because phosphate and calcium are on an exchange system, renal failure, not being able to balance those electrolytes through the kidney tubules and absorb them in the proper balance. And effects causes spontaneous stimulation of skeletal muscle, carpal pedal syndrome, spasm, that's cramping in the hands and in the feet, contraction of fingers, tingling fingers, mental confusion, irritability, arrhythmias, weak heart contraction, because the heart relies on extracellular calcium and has to do with that extended absolute refractory period that you see in the heart so it doesn't undergo tetanus. Tetanic contractions. Hypercalcemia. Uncontrolled release of calcium ions from bones due to neoplasms, tumors, hyperparathyroidism, immobility which decreases stress on bones, results in demineralization, increased intake of calcium, either vitamin D, which helps with calcium absorption, or calcium, increased take of milk or antacid. So, too much calcium, muscle weakness, lethargy, and stupor, often with personality changes, anorexia, nausea, polyuria, heart contractions increase in strength, and arrhythmias may develop. Increased PTH causes decreased bone density. So, a lot of things can happen with calcium. Magnesium. A lot of people are deficient in magnesium and don't really know that they have the problem. And this electrolyte here, or this ion, has a lot to do with helping to keep fluid balance, and it tends to be malabsorbed or seen in malabsorption and malnutrition, chronic alcoholism. And it tends to be involved with the tremors that you see in severe alcoholics. Overuse of diuretics, so you spill off a lot of magnesium, diabetic ketoacidosis, hyperparathyroidism, and hyperaldosteronism. And sometimes when you're retaining one electrolyte, you spill off the other one in exchange. So, neuromuscular irritability with tremors and chorea, that's involuntary repetitive movements, insomnia, personality changes, and increased heart rate with arrhythmias, because it upsets the calcium balance. Hypermagnesia, usually result of renal failure and not being able to balance all the electrolytes, and it can result in depressed neuromuscular function, leads to reduced reflex response, lethargy, and cardiac arrhythmias. Because if you have too much magnesium, it's generally interfering with calcium. So phosphate. If you don't have enough phosphate, usually it's something to do with malabsorption, losing it through diarrhea, excessive use of antacids, alkalosis, hyperparathyroidism, and the effects are impaired neurological function, tremors, weak reflexes, confusion, stupor, and decreased activity in blood cells. And when you're talking about all of these electrolytes, there's an interaction with all of them that's very difficult to explain in a very brief discussion here. You would have to spend a lot of time taking biochemistry and chemistry to really understand. So without me spending hours trying to get down to understanding the interactions, it's a long process. So we're just trying to minimize that. And if you have time at some point, take biochemistry. Take some of the more advanced upper level courses and have an understanding of how this works. And maybe at some point you will get to that you will get that time when you can do that. All right, quite an extensive study though. Hypochloremia. Now, chloride ions are found outside the cells with sodium, and a loss of chloride ions can be caused by alkalosis. So if you have alkalosis, usually, here's another thing you want to keep in mind. Chloride ions are on exchange with bicarb. So if you're retaining bicarb, which is a base, you're spilling off chloride ions, so that's your alkalosis going on. And also, when you're vomiting, you're losing HCl from stomach acid. Excessive sweating on a hot day causes loss of sodium chloride, which results in low sodium, low chloride ions. And also, it results in dehydration. Hyperchloremia, increased intake of sodium chloride, and this leads to edema and weight gain. So acid-base balance, here we go. Here's your normal serum pH, 7.35 to 7.45. And control mechanisms of serum pH, you have buffer systems. They're buffers. They circulate in the blood and they respond to pH changes immediately. Now the respiratory system can alter CO2 levels by changing respiratory rate. If you speed up the respiratory rate, you're going to lose CO2 and increase the pH. If respiratory rate slows down or you have respiratory impairment, then CO2 levels will increase, and that's going to drop the pH and cause acidosis. Kidneys can modify the excretion rate of acids and production and absorption of bicarb ions. So here's the hydrogen ion and the pH scale, and remember that the more H ions you have, the more acid the solution is. So there's your normal range, 7.35 to 7.45, and as you increase in acid, you increase H ions. If you go to a more alkaline level, then you're decreasing your H ions. And if you get to extremes, either side, it can result in death. So your buffer systems are composed of a weak acid and its alkaline salt. Neutralizes excess acid or base and helps maintain a relatively constant pH. Here are your four major buffer systems. The sodium bicarb carbonic acid system is what I really spend a lot of time with in A&P because it's very important in nursing and respiratory therapy. And phosphate is something that can bind up H ions and spill off a lot of acid in urine that way by binding to the phosphate ion. Hemoglobin can bind CO2 and remove that from the blood. It transports a certain amount of CO2. And protein buffer systems, there are some proteins that have an acid side chain, some have a base, and these can work. This is a little more complex. I'm not really going to get into that, but if you want to study that at some point, you can on your own. This is looking at the bicarbonic acid buffer system in picture form. And one thing you want to keep in mind is there is this balance between bicarb and carbonic acid that has to exist at all costs. And there's this 20-to-1 ratio of bicarb to carbonic acid that has to exist. And this is how it works. When you get rid of CO2, now you have less carbonic acid because you've broken it into CO2 and oxygen and spilled this off through respiration. And so your acid goes down, but then the cells are producing carbon dioxide from metabolism of glucose. And so cellular metabolism produces that acid, and then That goes into the production of more carbonic acid. And then H ions bind to bicarb in the buffer system. And then in the kidneys, carbonic acid is broken into bicarb and H ions are removed in urine. And now the blood has less H and more bicarb, so the bicarb goes back into the blood to work as a buffer to neutralize acids in the blood. Then the carbon dioxide given off by cells combines and forms carbonic acid, more acid in the blood and less bicarb, but then you're going to the lungs and you're getting rid of this CO2 by breaking apart the carbonic acid. So this is an ongoing thing, getting rid of acid, making acid, and constantly keeping that balance in place. So respiratory acid-base imbalances. So working through this diagram, causes of acidosis are respiratory congestion, could be drugs, alkalosis, hyperventilation, anxiety, aspirin overdose. The effect is increased carbon dioxide, which results in the acidosis, and alkalosis is decreased carbon dioxide. The compensation means the other system that's involved with this whole thing. The respiratory is one component, kidneys are the other side of the coin. And if the respiratory system is having the problem, the compensation comes from the kidneys. So the kidneys will secrete more H ions and absorb more bicarb, which is a base, to help offset the acidosis. In alkalosis, the kidneys excrete less H and reabsorb less bicarb, and this way you lower the pH and bring it back into normal range. So in the lab, what you'd see is you would see increased carbon dioxide and bicarb, and compensated pH would bring it back into a 7.35 to 7.45, and if it's decompensated and nothing's happening, the pH will be less than 7.33. Decreased carbon dioxide and bicarb would be what you would see in the lab, and compensated, the pH would be on the high side, 7.4 to 7.45. Decompensated would be above normal range. Metabolic acid-base imbalances. These are your causes. And with acidosis, you would see an decreased serum bicarb. So this is in the kidneys now, metabolic. So the compensation would come from the respiratory system now. So rapid, deep respirations, kidneys excrete more acid, increase bicarb absorption as the lungs are getting rid of CO2. So in the lab, you'd see decreased serum bicarb, decreased carbon dioxide. Compensated would be 7.35 to 7.4, decompensated below 7.33. Alkalosis, vomiting is in the early stage, excessive antacid intake, and the effect would be increased serum bicarb. Compensation by the respiratory system, slow down respiration, and you're going to retain more CO2 and decrease bicarb absorption in the kidneys, and so that compensation will bring things back to normal, and hopefully 7.4 to 7.45 compensation, decompensation, the pH is up above normal range. Changes in blood gases with acidosis. So what you see here, and this is a little bit harder to see, but it's showing you a scale, and it's showing you the balance of 20 to 1, your ratio of bicarb to carbonic acid. So in respiratory acidosis, what you see is you have too much carbonic acid, and the compensation is the kidneys increase serum bicarb and excrete more acids. Metabolic acidosis, the cause is loss of bicarbonate ions, excessive production of acids. So you see the acid is high there, and the compensation is decrease carbonic acid through the lungs and kidneys and bring it back to normal. Decompensation is it just keeps going in that direction. And this is usually what you're going to see a lot in the lab, is either respiratory related problems resulting in acidosis, or metabolic problems such as ketoacidosis, or some type of alcoholism or drug poisoning resulting in metabolic acidosis. So, respiratory acidosis causes increased carbon dioxide levels, pneumonia, asthma, chest injury, opiates, COPD. Metabolic acidosis, decreased bicarb levels, diarrhea, diabetic patients that produce large amounts of keto acids that use up bicarb ions, renal disease, and possibly dialysis is required. The effects of acidosis. Direct effects are manifested by the nervous system, which is depressed. Headache, lethargy, weakness, and confusion develop. Eventually, this leads to coma and death. So it's the neurological problems that are involved which result in the person's demise. Alkalosis, respiratory. Not really common. Usually, the major cause of respiratory alkalosis is hyperventilation anxiety attack. Sometimes high fever or aspirin overdose also does this. Metabolic alkalosis, increased serum bicarb from vomiting, hypokalemia, or excess ingestion of antacids. The effects of alkalosis increases the irritability of the nervous system, causing restlessness, muscle twitching, tingling, numbness of the fingers, and eventually tetany, seizures, and coma. So in both cases, these imbalances can result in death.